All right, so we're going to go on to a PowerPoint. I'm going to show you some of the pictures that we have on your in your module, but I'm going to talk about those a little bit and hopefully explain those to you a little bit better. And once you understand it, hopefully this all makes sense. So here we go. Let's share the screen. And there we go. So I'm going to turn off my video. You don't have to see me anymore. You're just going to hear me. So now let's start the show. Hold on a second. I'm trying to get this out of the way. Okay, we're ready to go now. All right, so in the case of the spinal cord, it's very important for you to understand that, you know, you have your vertebral levels. These are the little bones. And then, of course, as you remember your anatomy, you have the spinal canal in which the cord is. And you'll note that the cord's much thicker at the top and it gets narrower and narrower as it gets down to the bottom. And then when we get down to the bottom, we have this area right around T12 to L1 where we start going to cauda equina. The cord in most people ends somewhere between T12, L1. Here it shows it goes down to L2, but it's been my personal experience that that's actually kind of rare. You have a lot of nerves coming off here. That's referred to as the horse's tail or cauda equina. Keep that in mind because we're going to be talking about that in the syndromes later on. The other thing you need to remember is that it's much thicker up here than it is down here. It is much more unstable up here than it is through the thoracic area. Why? Because we have the ribs that help give us some stability. We have the rib cage and we have hypermobility at our necks. That's why we can move our heads around as much. We obviously can move our heads and our necks a lot more than we can move our lumbar spine down here. But your most common injuries from hyper extension and flexion are going to be here in the cervical region. And again, remember that the majority of, if you read your book, like 56% or so are quadriplegics or tetraplegics, same thing. And then paraplegics would be anybody really below this C8, T1 level, ends up being really a para. Even though they have involvement in the cervical segments. And when we talk about different levels of injury, that'll make sense as we pull all this together. Now, for the sake of this lecture, you can see that right around C5, or really like more like C4, you see how it starts coming out slightly below the vertebral body. So if we have the C1 vertebral body, the C2 nerve is coming out right underneath that. Then the C2 vertebral body, C3 is coming out. And so when you get patients, sometimes they'll say they had a C5 burst, which means if this one blew up, this C5 vertebra blew up and blasted back into the cord, you most likely are going to get, if this was C5, so C1, 2, 3, 4, 5, you see it's the C6 that is going to be damaged, not the C5 nerve root. So that's why sometimes you're like, well, they said they had a C5 injury. You always want to ask, is it bony injury or is that the neurological level? They're two different things. The bony level doesn't always match the neurological level. And we'll talk about zones of preservation, and we'll talk about spinal shock, and we'll talk about partial preservation areas, what that means. But what you need to understand here, just for right now, I want you to hold that thought, is the bony level does not always match neurological level. And if we go down, okay, see 1, 2, 3, 4, 5, 6, 7. So here's T1, okay. At T1, the T1 comes out underneath it. And so then it starts matching up a little more closely, depending on what level you end up at. And then when we get down here, the lumbar injuries will almost always be lower motor neuron injuries because there's so many nerves in and of themselves in just hanging out in the cord, not in the cord space, I'm sorry. I should say in the spinal column where the cord usually is. Down here, it's no longer a cord that's in there. It's just a bunch of nerves hanging out in there. So if somebody has a burst fracture of L3 or L4, like let's say somebody falls off of something and lands on their butt, that happens, and then they get a burst fracture, and the vertebral body blows back into here. There's almost no cord back in here for most people. And so what ends up happening is that person will be a lower motor neuron injury, even though they broke their back. So this anatomy part is important for you to have a visual of that. Okay, so let's go to our next slide. Now, this is very important for you to understand this map of the spinal cord. So this is a cross section of the spinal cord. This is probably up high. And it tells you where the different tracks are. You don't have to remember every single one of these tracks. The important ones for you to remember are the lateral cortical spinal tract, this big one. That's our primary motor tract. Then you have all these little ones. You don't really need to worry about those really. The anterior cortical spinal tract also has some motor components, but then the anterior lateral spinal thalamic tract, if you remembered that, carries primarily our sharp dull sensation and superficial touch and those kind of things. And then there's some light touch as well in the anterior cord here. This being the front of the cord, this being the back of the cord. So you cut it and we're looking straight down on top of it. Now, the thing that I think can get confusing about this picture is this is just showing you the sensory tracks, but those same tracks are over here as well. So one side is overlapped on the other. They're just showing you motors on one side and sensory on the other. Now, it's super important for you to understand that if I told you that this track right here is kind of laying, if I put it over onto this side, it's kind of laying right here, right? So really sharp, dull, and pain sensation and generalized sensation is hanging out right next to the lateral cortical spinal tract, our primary motor tract. So essentially, if you wipe out one side here, you're going to get sensory and motor impairment. Now, remember, sensory impairment goes up 1 or 2 levels. Sensory input, it's very important for you to remember that it goes up 1 or 2 levels and then crosses over and goes up on the other side. So sensation coming in on this side will end up being processed on the other side of the brain. Okay, and we'll talk about that when we get to what we call Brown-Séquard syndrome. Then we have the dorsal columns. And if you remember, your dorsal columns carry proprioception, vibration, 2-point discrimination. And these are your horns where things come in and go out, okay? Your ventral horns or your dorsal roots. That's what this gray matter part is. The other thing that doesn't show super well on here is as we lay down in each one of these tracks, okay? So if I'm looking at the cortical spinal tract or the lateral spinal thalamic tract, if you do it an independent little cross section of that, you will see that the cervical segments are more medial, and then they start coming and they start laying down further out. So cervical's most medial, then thoracic, then lumbar, and then all the way down. So basically, arms are on the inside here too. Arms are carried more medially, and that becomes very important when we talk about central cord syndrome, which we'll talk about in just a second. So the anatomy of the spinal cord is a map. And this map, based on your clinical exam, which you mostly won't be doing the clinical exam, but if you have a patient and they tell you, well, I have normal feeling on this side, but I can't move stuff on this side, but the side I can feel things on, I can't move, or what did I just tell you? So the sensory and the motor are flipped. I don't want to confuse you. So that person right there, by just telling you that the side I feel really good on, I have normal sensation on, is the side I can't move on. and vice versa, then you automatically know that person is a Brown's cord injury. And you already kind of know what happened to their cord. And so that's why it's important for you to understand that anatomy. Okay, so let's move on to the syndromes here. Okay, so you have these pictures in your book. Okay, and let's start with this anterior cord syndrome. All right, this frequently occurs because of a hyperflexion injury. This is your typical traumatic injury, but you see it's getting that lateral spinal thalamic tract, your all of your sensory components in the front and the lateral cord, all of your motor components, and they might have some proprioception spared, some 2-point, but very common that the whole cord can be wiped out. But if they end up having proprioception and 2-point discrimination, then that's a true anterior cord syndrome. And as you read in your book, this is pretty common from these flexion injuries. Okay. So next, this central cord syndrome is actually our most common spinal cord injury syndrome. And I personally have found that this occurs most likely because of falls or hyperextension injuries, and it creates a compressive force that squeezes. It has to do with the physical principles of, like, if you have a hose and you bend it back, it creates more pressure on the center than it does on the outside. And then because of that, you could get swelling and bleeding in here. And so what ends up happening with these people is they'll have some sensation and some stuff spared on the outside of the cord. And depending on how big this area of damage is, you may get all of the motor tracts impaired. You may have some sensation, because remember, this is the spinal thalamic tract, primary sensory tract, but that's again right next to it here. And then you could also have, if this circles in more, remember I said that the Remember I said that the cervical segments tend to be more here. So if this area of damage tends to be a little bit of a smaller circle, these people frequently have stronger lower extremities and some sensation, and they almost are always incomplete just by virtue of the fact that the entire cord isn't damaged. And we'll talk about complete versus incomplete in a little bit. And so what ends up happening is they frequently have more upper extremity dysfunction. I had one guy that was he got injured skiing. He was a middle-aged man. He was a dentist of all people. This is the one guy that could have been a para and kept his work without problem. But what ended up happening, I'm going to come back on video here. What ended up happening on him is that he got, because he was snowboarding and he fell, hyperextension injury, ended up with this central cord problem right here. And he was walking just fine. He was moving and he couldn't use his hands. So it was like, really, I mean, of all the things, this is the one thing this man needed, and he couldn't have it. But most people seeing him walking around wouldn't notice that he had a spinal cord injury, but he did. And so I had one lady who was walking around on a respirator because her cord damage was so central, it just affected respiration. And she was walking and moving her arms just fine. So it can really vary, but these inherently are incomplete. Okay. And then we have this Brown's cord that I was talking about. Remember, that's the one where one side is wiped out. So basically, you're going to have sensation and the cortical spinal tract. So this is just showing it here, but remember, this little circle is over here. It's all wiped out. This frequently, they say, happens because of stab wounds, but I'll tell you from experience that central cords frequently have a Brown's cord kind of look, meaning that the circle isn't always perfect. And so one side is more impaired than the other. This circle can be shifted over here. So it's not uncommon to have central cords with Brown's cord-like syndromes, primarily being that the side that the sensation is absent on is the side with the normal motor control and vice versa. So they flip-flop. Okay. And so that's really important. So when you're like, wow, you have normal feeling over here, how come your motor isn't normal over here? That's because they're a bronze cord. Okay. And so it doesn't always have to be because of a knife or a penetration injury. However, something that is not shown here is, but it is talked about in your score builders book, is dorsal column or posterior cord syndrome. Not as common as these three syndromes. However, when I was on the spinal cord injury service at Rancho, did see one or two of these, and it was very interesting. And those indeed were because of penetration injuries, stab wounds and stuff. So the knife just came in and went out, didn't go all the way across. And it just basically wiped out proprioception and coordination and those things. And these people had totally normal strength and normal sensation, and they were so impaired despite the fact that they had normal strength and sensation, because they didn't know what to do with it. And it was really a shame, because here they had all the strength, but they couldn't harness it. And so I remember way back at the beginning, we talked about the fact that it's not so much about the strength, but it's about having the sensory input and knowing how to modulate that strength. And this is why in spinal cord injury, they have more problems with movement and walking than perhaps somebody that got polio. When we get to polio and post-polio syndrome, that was truly a ventral horn disease, which means that's where it was only motor and there was no sensory component to it. And those people could do a lot more with a lot less strength, as opposed to someone who has no sensation coming in and possibly the entire cord wiped out. Maybe it was severed or a complete anterior dislocation of the cord. So the moral of the story is, without sensory input, you don't really know what to do with your motors. And that was case in point when I'm talking about this posterior columns, or what they refer to as posterior cord syndrome. Now, that being said, I am going to talk just briefly about spinal dislocations and subluxations and so on. So it was not uncommon for people to say, well, you know, the doctor said that my spinal cord was just bruised. It wasn't severed. Okay. And I feel that was always somewhat misleading, because if the cord was swallowed upon and things in here died, central nervous system, they didn't really have a great opportunity to grow back and change. So we will talk about some of the newest research out there in plasticity of the spinal cord, but that's not really where we're at yet, but it is coming down the pipes. So what I want you to understand is bruised, cut, damaged, whatever word they used, the clinical manifestation of what you're seeing with that patient to present is telling you what happened to the cord. It is not an MRI or a picture that tells them how bad that damage is. Okay. So obviously someone whose cord's intact is going to feel like they're a lot better than somebody that had it just cut with like a chainsaw or something, of course. But the point is that the insult to the cord, if it's been lack of blood flow or swelled upon, the zones of injury may decrease just a bit, and they may get what they call partial sparing or zones of sparing. But ultimately, that full recovery, what people want to see, because bruises go away, right? I mean, that's why I think that's just a bad word to use. And once your cord gets damaged to that level and you have the paralysis, the chance of it coming all the way back are highly unlikely. So there are periods of recovery, which we expect, and there's good prognostic indicators, and we'll talk about that in a little bit. So those are your cord syndromes, the anatomy of the cord. I urge you to read through that and try to understand that. Your take-home messages are, your most common is your central cord syndrome. They're almost always incomplete. Oh, we forgot Cauda equina syndrome. So back to this one right here. So I don't have a picture of that because now if you did a cross section of the cord down here, there's no cord down here. If we did that same cross section right here, there would just be a lot of peripheral nerves running in that canal. And so when we have an injury, Cauda equina syndrome is by definition incomplete and also lower motor neuron. When you are higher up in the cord, they're having upper motor neuron symptoms, which include all those positive signs we talked about, right? Remember those back at the very beginning. Upper motor neuron syndrome below the level of injury, at the level of injury, right where you might have blasted through or torn or stretched a peripheral nerve, they frequently have lower motor neuron. It's not uncommon for them at their level of injury or fracture, subluxation, whatever they had, for that nerve root to be stretched or damaged. And so if you try to electrically stimulate that and they happen to be a C6 and you're trying to stimulate a C6 muscle, you're like, why am I not getting a response? Because it's lower motor neuron. Below the level of injury, however, it'll be upper motor neuron and it'll be fully innervated and it will respond quite well to electrical stimulation. So those are called the laws of the spinal cord. At the level of injury, it's not uncommon to have lower motor neuron damage. Below the level of injury, if it's at the cord level, will be upper motor neuron. If you are down here, it's going to be lower motor neuron. Done deal. There's no cord there to be damaged.